Good evening. I would like to welcome you all for the academic presentations of Registrars. And I would like to welcome all the esteemed teachers who have joined with us, and especially Madam Lalanta Senaratna, who is continuously guiding us in a dedicated manner without considering her tired schedule, always trying to correct us our presentations. And today, from today onwards, this activity will be carried out under the college, the Sri Lanka College of Specialist Family Physicians. And I would like to invite Madam Lalanta Senaratna to address few words, if possible, to initiate this event. Dear Madam.
I think, Shamen, you better start now.
Okay, Madam. Thank you. So I would like to invite Dr. Taranga to introduce today's speaker.
Okay, thank you, Prabhat. Good evening, everybody. Today, our presenter is Dr. Shamen Lakmal de Silva, Registrar in Family Medicine. A brief introduction of him. He was graduated from University of Jaffna and he did his internship at District General Hospital, Trincomalee. After that, he worked as enthusiastic surgical senior house officer as orthopedic at Base Hospital, Homagama. And currently, he is doing his appointments at NHSL. So, Shaman, this is over to you. Please continue.
Dr. Shamen, I think you can share the screen.
Okay. Can you see my desktop?
Yeah, we can see.
Yeah. Good afternoon, all of you. I'm Dr. Shamen. I'm the first year registrar in MD Family Medicine. So today my topic is acute coronary syndrome and the contribution by the primary care physician in the management. So this topic, I thought of doing this topic because I did cardiology appointment recently. So I reasoned that during that appointment, I saw a lot of patients and young chap. I mimicked my thought of doing this presentation because of he's a young and so he had chest pain. So my patient is 36-year-old Mr. Asankar. He presented with chest pain on 2013 July 19 on 8 p.m. So it was a central tightening like chest pain. So it was radiated to left upper limb and neck, lasting more than 30 minutes. So it's an unbearable pain. So it associated with nausea, excessive sweating, and shortness of breath. And he during my history taking, he never experienced such a kind of chest pain in the past. and it was occurred while he watching the television. So, further elaborating his history, he haven't any past medical history such as hypertension, diabetic, or anything, and not undergone any surgery, and not known allergy to any foods or pasta or uh, drugs, and he has a family history of hypertension, and his mother and father is having, and no young death in family. And further, I took his social history. He's a father of 2 children and businessman in Manin market. So daily income is 10,000 rupees per day, and he's a smoker, 11 pack here, and consume alcohol 30 units per week. So further, I uh, with this short history, I did my examination, and his moderately built and BMI 32 and ill looking, and pulse rate was 52 beat per minute, and blood pressure was 120 by 70, and no murmur, dual rhythm, and vesicular breathing, and no added sound. So with the history and examination, short history and examination, what could be the differential diagnosis?
Shaman, it can be a ischemic heart disease
Yes,
and gastroesophageal reflux disease.
yes.
Um,
Anything?
pulmonary embolism.
Yeah, yeah. Tarang is correct. So I thought of acute myocardial infarction. It may be pneumothorax and pulmonary embolism and aortic dissection. So with that differential diagnosis, so further uh, following his chest pain, so it occurred at 8 p.m. So he went to nearest general practitioner, primary uh, physician near his home around 8:30 p.m. So with that history and his presentation, the general practitioner thought of uh, it was a chest pain, and it's more likely to the acute coronary syndrome and acute myocardial infarction. So he was ensured that he need tertiary care. So without delay in the general practitioner, he asked to go to the National Hospital ETU. So he didn't wait for ECG or any loading doses. So because he is nearby NHSL, 10 minutes apart from his home, he directly came to the National Hospital. So this is his ECG. It was took in the ETU at around 9:17 p.m. So can anyone tell what's wrong with this ECG?
Shaman, it's look posterior MI.
Yeah, more than that. Yeah, Tarang, you are correct, but there's a 2-3 AVF, there's a ST elevation, so infero posterior with, and there's a lateral lead also involving. So infero posterior with lateral extension, ECG. So infero posterior STEMI with lateral extension also there. So in the ETU, there's 920 around 920 that got called to cardiology unit 4, and they booked the catheter lab and do the coronary angiogram and primary PCI. So they plan to coronary angiogram primary PCI around 9:20, around 10. So it did around 10. So coronary angiogram, there was an acute thrombotic occlusion in left circumflex artery, and with that they did the primary PCI to left coronary left circumflex artery. So this short history and treatment that caused life saving of this patient. So he then he transferred to the cardiac unit and CCU, and with in that CCU I saw the patient, and retrospectively I took the history. That was my initial that was my point to do this presentation. So with that presentation of the patient, I would like to elaborate. So what is acute coronary syndrome? All we know that is what is acute coronary syndrome. So as my patient having pain, that's main symptoms: pain, pressure, tightness, and burning like pain. So at the same time, chest pain equivalent symptoms also we are encounter recently or day-to-day life, and dyspnea and epigastric pain and pain in the left arm. So this kind of people also we are day-to-day we are seeing uh, uh, during our practice. So with that, the ST segment, so there are with ECG, so it is a easily we can diagnose with ECG. So with ECG, we can divide two groups. So ST segment elevation ACS and non-ST segment elevation ACS. So non-STEMI or STEMI. So with the diagnosis, acute chest pain, so more than 20 minutes with ST segment elevation, we can easily diagnose. So with the diagnosis of primary this ST elevation MI, so the management plan is mainstay of the treatment is immediate reperfusion by primary percutaneous coronary primary PCI. If not available, we have to do fibrolytic therapy. So as my patient did in the NHSL is correct. So he is not waiting for any clarification or any troponin level. So we did the correct thing to him. So non-ST segment elevation MI, non-STEMI. So patient feel pain, as of acute chest discomfort, no persistent ST segment elevation. So it may be presented with ST elevation, transient ST elevation, persistent or transient ST segment depression, T inversion, flat T waves, or pseudo normalization of T wave, or ECG may be normal. So with that, go for the unstable angina. So unstable angina is defined as a myocardial ischemia at rest or minimal exertion in the absence of acute cardiomyocyte injury or necrosis. So we recently encountered this kind of people also. With the ECG, there's nothing, but they have chest pain in with minimal exertion or in the normal in the rest. So unstable angina, so and non-STEMI, non-ST elevation MI, we can diagnose with high sensitivity cardiac troponin assay. So recently, in researchers, they did introduce the high sensitivity troponin test, troponin assay, instead of standard troponin assay. The high chance of detection of acute MI is more. So absolute 4% and 20% relative increase. So at the same time, compare with non-STEMI patient, individuals with unstable angina do not experience, experience acute cardiomyocyte injury necrosis, have a substantially lower risk of death. So according to researcher, so unstable angina have lower risk of death. So we don't want to we don't want to start antiplatelet therapy or invasive strategy within 72 hours. So this is a summary of that ST elevation and ST as I told earlier, is acute non-STEMI and STEMI. So high troponin, high sensitivity troponin, they normally we are doing in 0 hour and after 2 to 4 hours. So normal next place. So single IV bolus according to the weight we can give. So following the initial lytic therapy, it is recommended to transfer the patient to PCI center. As I mentioned, even though patient is more than 120 minutes, go for the delay. So we do fibrinolytic therapy in the base hospital level. So we can arrange and get a call to a primary PCS center and arrange a book the bed, then we can transfer the patient. In case of failed fibrinolysis, or if there's evidence of re-occlusion or reinfarction with recurrence of ST segment elevation, even though we do the fibrinolysis, so we can do the ECG after 1 hour. So we can if we see ST elevation, still ST elevation, immediate angiography and rescue PCI is indicated. So so as ACS, we have non-ST elevation MI also. So it's brief. Is a summary of the non-ST elevated ACS. So if suspected of any ECGs with non-ST elevation MI, so we do high sensitivity troponin. As I earlier mentioned, high sensitivity troponin. We can rule out the non-STEMI elevation MI. So high sensitivity troponin 0 or 1 hour or 2 hour. If it is high sensitive, we can rule out and we can discharge the patient. And further, additionally, we can do the stress angiography in later. If his high sensitivity troponin is positive, so we can rule in he's having MI and we send to the CCU, and further angiography and echocardiography we can do. So if it is not in the 0 or 1 hour, we can do after 3 hours also. So he has chest pain and ECG is still changing ECG. So after 3 hour high sensitive troponin, so we can arrange echocardiography and send to ward, and we can plan later stress testing and CT angiogram. So So with that brief summary, for primary care physician, so we we usually see this patient after initial treatment in the cardiology unit, and uh, we do uh, we do alteration of medicine, and we can give the lifestyle in interventions and risk factor control in that patient. So main risk is this patient. We saw this patient. Recently encountered that patient. He's having smoking, history of smoking, and he's taking more than 30 units of alcohol. So without lifestyle modification, we can't prevent further he's getting acute MI. So his mainstay of this treatment is lifestyle interventions, include he's having smoking and he's obese. We have to advise his weight control and encountering physical activity and blood pressure control. He's even though he is not hypertensive, we can uh, we can advise other risk factors also. So main thing is uh, I advise the patient is a cessation of smoking. So actually, smoking is a strong pre-thrombotic effects. So smoking cessation is potentially the most cost-effective as well as secondary prevention measures. And we did the dietary modification of that patient. So we, with the help of dietitian in the NHSL CCU, we gave the dietary plan on 120 his calorie diet will be sufficient for the day. So at the meantime, it's a vegetarian diet and maximum 10% of total energy intake from saturated fat. We advise with nutritionist in during the CCU admission. So at the same time, he advised on less salt intake, less than 5 grams per day, and fiber diet per day, 30 to 40 gram fibers. And we encourage to get the fruits more than 200 grams and vegetables also 200. And he advised fish 1 to 2 times per week, especially oily varieties, and 30 gram unsaturated nuts daily. He asked to get nuts and groundnuts for 30 gram full hands of groundnuts. At the same time, limited alcohol intake. So actually, he's he's taking 30 units per week. So we asked to reduce, and uh, we asked to discourage them. So at the same time, discouraging the sugar sweetened drinks also. He has a many. He's works in many market, so he usually drinks some Coca-Colas and Sprite. So we strongly discourage that habits. At the same time, exercise-based cardiac rehabilitation. So we do advise and we refer him to physiotherapy cardiac rehabilitation unit in the NHSL. So all the acute MI patients should participate in exercise-based cardiac rehabilitation program. So with the rehabilitation program, we have exercise training, risk factor modification, and education, stress management, and psychological support. Mainly cardiac rehabilitation done by physiotherapists, group of physiotherapists. So they doing after the discharge and during the stay period of the ward, he initiate the cardiac rehabilitation, and they as outpatient program they continue follow for 1 year duration, and that improves quality of the life, functional capacity, early return to work, and development of self-management. At the same time, resumption of activities. As this new guideline says, extended sick leaves is usually not beneficial, and light to moderate physical activity after discharge should be encouraged. With that cardiac rehabilitation program, we asked to do the moderate to physical activity as he following that out as an outpatient patient to the cardiac rehabilitation unit. So they mentioned that sexual activity can be resumed early if adjusted to physical ability. So there's no such time limitation for sexual activity, but they mentioned that cardiac rehabilitation, after cardiac rehabilitation, they can engage in sexual activity. At the same time, uncomplicated. The main thing worry of the patient is traveling. So that guideline says it's uncomplicated, completely revascularized MI with ejection fraction more than 40, risk is low. So after 3 days hospital discharge, they can travel. But if patient is complicated STEMI and including patient with heart failure, ejection fraction less than 40, or residual ischemia, arrhythmia, and traveling should be benefited until the condition is stable. So at the same time, blood pressure control also is a mainstay of the treatment. So lifestyle changes including reduced salt intake and increased physical activity and weight loss. So pharmacotherapy with systolic blood pressure less than 140 should be initiated. So adherent to the treatment, so patient after discharge, so early as possible, we have to engage in has to come to the clinic. So delayed outpatient follow-up after MI, so was short and long-term medication adherence. So we have to adhere some medications. As we know, we start dual antiplatelet during catalog and catheterization. So aspirin we do start 300 in loading dose, but in follow-up we tend to give 75 to 100 milligram. At the same time, dual antiplatelet we do use clopid, and there are prasugrel and ticagrelor. So it's recommended after STEMI who is undergoing primary PCI up to 12 months. So per se, patient is going underwent only fibrinolysis therapy without primary PCI. We give the dual antiplatelet for 1 month only. So long-term treatment with oral beta blockers is started after STEMI. The a new guideline says is during the hospital stay we should start beta blockers. And statins start following STEMI's secondary prevention. Also, we started 80 milligram during the PCI, and then we reduced to 40. So AC inhibitors are recommended patient with impaired left ventricular ejection fraction less than 40 who have experienced heart failure in the early phase. So treatment with AC inhibitors is recommended in patients with systolic LV dysfunction or heart failure, hypertension, and diabetes, and should be considered in all STEMI patients. So patients who do not tolerate an AC inhibitor should be given an angiotensin to receptor blockers, ARB. So with that medication and cardiac rehabilitation, so we start on treatment and we continue the treatment, and we gave the early date for the clinic and cardiac rehabilitation. Patient safe, and he is willing to adhere to the medication. At the same time, he is willing to adhere to his lifestyle modification. And with that history, so my take home message is early diagnosis and prompt initiation of revascularization therapy is key to success in the management of STEMI. Reperfusion delays could be minimized, educating the patient population and improving the care in emergency department. So develop infrastructure and maximizing using available cath lab facilities for patients with acute coronary events would significantly reduce cardiac mobility and mortality. So educating children from early days to healthy lifestyle would be the only long-lasting solution for this ever-increasing but preventable disease. So with this take-home message, I think you got some informations from my presentation. So this is my reference. So any question from audience, I can.
Shaman, you said some STEMI and acute coronary syndrome. What's the actual difference in management? Non-STEMI and acute unstable angina. Sorry.
Hello, okay.
What's the management difference between non-STEMI and unstable angina? You said something, but I couldn't.
Yeah, that thing is that the guideline says that as we are seeing the patient, so unstable angina, so we do uh, uh, if they're well enough, so ECG is it's not clearly seeing this thing. So we do the high sensitivity troponin. So with that, if it is the unstable angina, they clearly mention it is no need to do anything. So no need to start loading dose or no need to start any intervention.
In unstable angina.
Yeah, unstable angina.
But usually we give low molecular weight heparin and stat doses for unstable angina also. It may be changing guideline.
Yeah, that the ACS guideline is telling unstable angina that I earlier mentioned that presentation. So that compared to the non-STEMI, so individuals with unstable angina do not experience acute cardiomyocytes or injury or necrosis, have a susceptibility lower risk of death, so and appear to derive less benefit from the intensified antiplatelet therapy, as well as invasive strategy within 72 hours.
Okay, Shaman, thank you.
Any other questions?
Shaman, you mentioned that the people, when the facilities are not available for primary PCI, fibrinolytic therapy is done. In that instance, what is the next step after fibrinolytic therapy?
Yeah, that in my chart, fibrinolytic therapy, the more if ST elevation MI, if takes more than 120 minutes, we can 120 minutes we do the fibrinolytic therapy. So with fibrinolytic therapy, the guideline says we should transfer to the primary PCI center. because with fibrillary therapy, we can have that kind of that recur again. Again, we can have that reperfusion injury and that. So they asked to that fail fibrolysis. So if there is evidence of reocclusion. So recurrence ST segment elevation or immediate angiography in rescue PCI is indicated. So that guideline says it's better to transfer to the primary PCI unit. But in Sri Lanka, that won't happen. So after primary fibrillary therapy, they continue the same medication as aspirin, clopidogrel, and enoxaparin also we are giving. So is that clear?
Yeah, in our setting, that means if only those indications are there, patients are transferred
Patient is
to.
transferred. Yeah.
Yeah. Normally, the continuation is done in the same unit, right?
Yeah,
Am I
yeah.
correct? Yeah.
Yeah.
Yeah. Okay. Thank you.
Shaman, my other
Yeah.
question is, when a patient with chest pain comes to our GP practice, I think we should take the ECG and give stat doses before transferring to the hospital.
Yeah,
In
yeah,
this case, he has directly sent to the hospital. What do you think? What is
yeah.
better
Actually,
management?
my patient is near to the NHSL, less than 10 minutes. So
Yeah.
it's he didn't delay even ECG. I think he took 5 to 10 minutes, and he should give the loading dose. It's easy to that ETU people also, but we tend to give, but he didn't give the
Yeah.
loading dose, and without ECG, he believe on clinical symptoms, and he is saying. So actually, the thing is that we can do the ECG and diagnose, and we give the loading dose, and transit is better because the loading dose is aspirin and clopid. We give the normally it's the usually it takes 2.5 hours to work. So we are giving loading dose as 300, 680. It takes 2 hours to act. So with that, we can transfer the during the cath lab. It's working. That medication is working to during that time. So it's better to give during the first initial thing.
Okay. Okay. Thank you, Shaman. Shaman, my other question is, you told that if 0 hour and 1 hour high sensitivity troponin is negative, we can safely discharge the patient. But
Yeah.
I have heard we have to do high sensitivity troponin hourly until 6 hours before discharge. Because in Sri Lanka, I have seen troponin become positive even after 3 hours. High sensitivity troponin become positive even after 3 hours in Sri Lanka.
Yeah. Yeah, the thing is that guidelines, the ACS recent guidelines says 0 to 1 hour, and if it is symptoms is still there, so after 3 hours. So I want to read out that I didn't aware of that, but I mainly focus on guideline, and they says 0 hour or 1 hour, and then after 3 hours. I want to
Okay.
see and
Okay, then we have to do 3 hour one also.
yeah.
Okay. Okay, then, Shaman. Thank you.
Okay.
Dr. Shaman, Dr. Shamin here.
Yeah.
We, as the loading dose, clopidogrel 300 or up to 600.
Yes.
And then, as a primary care physician, what do you think? Giving straight away 600 is we give 300, or and that another 300 to be given by, I mean, the cardiology people. What do you think?
Yeah,
Usually we are practicing giving 300, no?
yeah, normally we
Patient.
are practicing 300, but guideline says that time limitation, that aspirin, clopid, that we usually takes that combination, usually dual antiplatelet therapy takes nearly 2.5 hours. So they mentioned that in the guideline, clopidogrel we can go up to 600. So it easily that it works less than 2 hours. So two to 2.5 hours. So during the when he come to the primary PCI, so it usually works during that period and it helps. But even though we are giving 300, so in ETU 300 it may takes more longer. So I never encounter this kind of thing in during the guideline reading. So actually, I don't know what's mechanism under behind that.
Yeah, thank you.
Shaman,
Yes, madam.
now, you know what I gathered from the presentation. Now there is a confusion regarding this antiplatelet therapy, right? So you have to be precisely say, you better tell now. So how we start, how much we start, how long you have to do. And I mean, like, I'm talking about dual antiplatelets, right? In what condition? Because I have heard that we have to stop in 1 month for some instances. So we have to be clearly say, in this particular condition, we have to start this much, because it is irrespective whether it start by the primary care or the cardiology, it goes to the patient's life. Like, it's way to understand that. It's because of that, we had to have some sort of understanding why we are giving, how much we have to give, for what are the conditions we give this much of aspirin or the dual therapy, and how we are going to stop. That is the first thing you have to clarify. The second thing is regarding statins. Right, I have seen even the day before yesterday, it was announced to me again, and about 75-year-old lady. At that time, he had heart failure plus some arrhythmias during that period of infarction. And, after about, now I saw the patient after 4 years, because it was a referral from the medical officers. Then I noticed they have stopped the full amount of high intensity statins. Then they just continue with atorvastatin 10 milligram. So those are the questions, and they don't understand how long we have to give, how much we have to give, and all sort of things. We have to be very clear about those two, about dual antiplatelet and statins. Since when they go for the lipid profile, when it comes to very low, what the people do is they nicely reduce the dosage, just not high intensity, just not even moderate intensity. It's lesser than that. So then we have to be there should be some sort of theory or the logic behind why we give statins. So if you reduce the dosage, what will be the repercussions? So those are the things we have to understand, and we have to do the needful. Ultimately, that is how we should support as primary care physicians to the very highly specialized cardiologist or whoever in the cath lab, as well as in the cardiology units, to save the patient's life. So I think we have to be very clear about the things I've mentioned.
Yes, ma'am.
So you better either you better tell now, or at least make anybody should take some sort of responsibility. I think it's your responsibility. You have to answer the questions I told now and give a it should be in a box. So should be, we have to start. These are the instances. I like the way. Otherwise, you are not sure what you are going to do for this patient. Because again, I think few people again go through the the guidelines. Oh, it's your duty, Shamen, to do that job. If you can give any sort of a answer, so to some extent, the kind of questions I raised.
Yeah, madam. So clearly that in practice, we started loading doses. So as madam says, aspirin we normally practice 300 and clopid 300 and atorvastatin 80. So with this dual antiplatelet, it going to work within 2 hours. So in the primary care, we can give the loading dose. So up to PCI, primary percutaneous intervention. So we have to have this dual antiplatelet. So if he is doing did primary PCI up to 1 year, so we continue dual antiplatelet, and after 1 year we stop clopid and continue aspirin 75. So if patient is did fibrinolytic therapy, not doing primary PCI, so we continue aspirin and clopid for 1 year, 1 month, and discontinue clopid and continue aspirin.
So that is the query, that means in the patients with AI, sometimes, I have seen the 10-act replace. Now it's so then after this thing, so do you think that the people will stop this and do all antiplate after 1 month? What I'm talking about, the current practice, the current trend, not the guidelines. Even all the other specialists or the physicians, whoever whatever the physicians are available in the country, do they stop?
No, madam.
So that's the thing. So we have to be very careful. So now, if the others are not doing, who are the people then they do it? Either cardiologists, they do that. If they're not doing the primary PCI, just the fibrinolytic therapy like tenecteplase, then they sort of discharge the patient. And then do they ask these people to stop dual antiplatelet in 1 month?
Yes, madam.
If so, they have to write clearly in the book, whatever the follow-up book or whatever in the diagnosis card, stop dual antiplatelet in 1 month's time. Have you seen that type of a statement in either a book or the diagnosis card?
No.
Have you seen?
No, madam.
So that is what, those are the things we have to be clarified. So if we do those things, then if the other disciplines, they don't do that, then they said we do not know what. And the other thing, so the person may be developed first time the acute coronary syndrome, and then we treat whatever the way, either primary PCI or not, and we discharge the patient and we ask the person to stop dual antiplatelet after 1 month. And there will be some, if the patient is not listen to me, if the patient is not compliant enough to stop all the contributory factors such as smoking as well as the lifestyle, other lifestyle modification, there's a higher chance of getting another coronary event. So then I think, though the guideline says we must have some sort of an idea, identify it's a very personalized care, the very personalized assessment of the patient, whether they are compliant enough to do that. Like most, or even daily, I see patients with all sort of coronary events, they do smoking, they do not stop, they do take alcohol. So then it's up to maybe sometimes they don't have this non-STEMI or the STEMI, then they have some sort of symptoms suggestive of unstable angina. What is the story about unstable angina, Shaman, then? Yes, Shaman, I'm talking to you.
So
If you are not sure about that, I think we must have some clear idea, because again, I'm telling again and again, whatever the things there in the guidelines, our specialty is different and unique. We do not practice what is there all the time in the guidelines, because it should be a very individualized and personalized care. So if we do not assess the patient comprehensively, we cannot do's and don'ts, we cannot practice any of those things, right? So ultimately, if the patient has another attack, or if the patient have any sort of near-death experience, then the whole sort of blame will go to the primary care physician if you do those things. So that means, so we have to have a very good, correct assessment of the patient. Anyway, what are your ideas? I think it's this question. I think this might, again, not a question, it's a statement. What about your idea about this? Shamen, are you ready to talk about unstable angina, about this antiplatelet and all these things, or else what do you want to do that? I mean, today you talk about, or you need some time to study and come?
yeah, madam, I want time to study and come, because I got now I'm confusing what to tell.
Yeah, that's what, it's not a joke, no. Now we are dealing with somebody else's life, right? So then we have to get together and we have to sit and we have to say, okay, this is the guidelines as this. And, the patients are not textbook sort of descriptions. So they're totally different. We have to get some support from guidelines to practice correctly. That means evidence-based. Guidelines means all the statement. It could be level 1 evidence. Otherwise, you cannot make those statements in the guidelines. Yes, that practicing guidelines means the evidence-based medicine. But again, so the individualized assessment of individual, very personalized case important. Because of that, better go through again. What do you mean by this unstable angina? Because if you do not ask these questions specifically, they don't come up unstable angina, about the symptoms and signs and everything, and you unnecessarily you stop everything and they will again having, because it's normal thing when once they have one attack, the second and third, they just it's very comes very easily because the risk is very high for the second and third. Not only that, so we have to think about not only the coronary circulation, we have to think about the cerebral vascular, the circulation as well. So it's a little bit of a very, very risky statement if we say, yes, we cannot don't have these concrete statements for those things, right? We must have some. It's good that you talk about, because it's still it's vague, and the statements in the guidelines, they say this and that, but ultimately even the cardiologist, they say, though the guideline says like this, because now we have the patient has this thing and that thing, because of we had to deviate from those guidelines, and we do practice like that. So that's how this explanation of the justification for the management plan. Accordingly, we had to do the same thing. And I think better, what is the guideline? Better circulate the guideline with the others.
Okay.
But even to me, we had to go through it. And anyway, I would like to have some sort of discussions with the cardiologist, and not maybe Fave, and we had to ask what is the sort of the duty of a primary care physician during this sort of a management, because that is the topic I would like to sort of give it to you all, not just count on acute coronary syndrome. It is how we help this cardiologist or the intensive management people to do save the patient's life as primary care physicians. Okay, now, because it's more like 12, 11 o'clock now, I'm also so tired. If you have any questions, because just my just thoughts came to my mind by listening, and it could be maybe correct or wrong, but anyway, those are the things. It's not practical if we go by all the guidelines. That's my personal idea. We must have, it's open for you all to give your personal experience as well as your idea, and then we must have some sort of a discussion. I would like to arrange some, I think, for you all as well as for the others, the CPD with the cardiologists, to have some sort of a correct idea what you're supposed to do. And anyway, Shane, it's over to you, and then better talk about that. And then next time, before the next session or the presentation, you better go through, maybe the few of you all can go through this, and then come with some sort of maybe a box or whatever, that's a little small document, and you can share with the group. That means group in the sense family medicine family group. So then we can distribute this to the DFMs and all the things who are waiting to do the MD family medicine or whoever. Okay, then I will stop here, and it's over to you all.
Thank you very much.
Thank you, madam.
Thank you, madam.
Okay, then good night.
Good night, madam.
Good night, madam.
Good
Thank
night,
you very
madam.
much, madam.
Thank you, madam.